We have a dedicated neuro ICU along with the critical care team, neuro SDO and 5 modular operation theatres. We have some special equipments like 4 high-end microscopes, 2 neuronavigation system through which we can pinpoint, localize the lesion, deep-seated lesion without much damaging the brain. We are very thankful to our management team too, because we have got 1 co-arm machine and 2 C-arm. We have a dedicated neuroendoscopy through which we did incision-less surgery like pituitary and both as well as cranial as well as spinal. We are highest in number of cases in Rajasthan using OARM, more than 750 cases in last 2 years, one of the best outcomes. This OARM machine gives us 2-dimensional, 3-dimensional real-time images through which we can put precisely screws without damage the nerve roots. Our future plans, we are going to do spine surgery workshop in upcoming 24, more number of academic seats to establish neurosurgical simulation labs, expansion of the infrastructures, integrated neurosciences department, deep brain stimulation, and we are in the process of installation very soon in Rajasthan, and this new armamentarium will provide new dimension to the neurosurgical treatment through cyberknife. In addition to our dedication to patient care, our neurosurgery department provides a robust educational framework that includes daily classes and ward rounds. Our daily classes covers a wide range of neurosurgical topics from basic principle to latest advancement, led by the experienced faculty and the guest speakers. Our academic training programs are designed to cultivate the next generation of neurosurgical leaders, equipping them with the knowledge, technical expertise, and ethical principle essential for success in this demanding field. In last few years, we have a total number of publications of 36, along with a total number of case reports of 8. We got Best Poster Presentation Award recently in WS conferences in August 2024 with faculty lectures by Dr. Pankaj Gupta. One of the best outcomes in the and good remission rate in the Cushing disease, along with our resident presenting the international. Now, I like Dr. Shubhrashankha Sen to present today's CCR topic, a very rare and interesting case of 18-year-old boy with a bilateral lower limb weakness. Thank you.
Good morning, respected chairperson, respected faculties, my dear colleagues. Today we are presenting a case of an 18-year-old boy with bilateral lower limb weakness. So the boy was 18-year-old resident from Hanumangarh from Rajasthan. He came to our OPD with complaints of weakness in both his lower limbs since last 5 months, along with stiffness and numbness in both lower limbs since last 15 days. In history of presenting illness, progression of weakness was observed in his both lower limbs while riding bicycle for the first time, more on left side. It was insidious on onset, gradually progressive, first felt over his left ankle and later is progressed ascending order from towards his leg and thighs. Since last 15 days, weakness progressed rapidly, leading to difficulty in walking without support, dragging of left foot, difficulty in negotiating feet in slippers, inability to get up from squatting position, even he needed support to get up from bed. He also complained of stiffness since last 15 days, which was bilaterally, and he first felt it while wearing trousers, and it was more on left side rather than right side. It was also insidious in onset, gradually progressive, required wall support also, and he was unable to get down the stairs, caused walking difficulty in bending knees. He also took medication from local practitioners. Patient also felt decreased sensation since last 15 days. His decreased sensations below subcostal level towards the bilateral lower limb. He first felt this on his bilateral legs while washing feet, which gradually started feeling heaviness in bilateral lower limbs. He also felt decreased sensation of his clothing like trousers, gradually progressed to his thigh and lower chest level, which is constant in nature. He also felt a band-like sensation around the upper abdomen with a wool-like sensation while walking on bare feet. Coming to negative history, patient didn't have any preceding history of any trauma or any lumbar puncture, no complaint of any radicular or funicular pain, no weakness or numbness of any upper limbs, any bladder or bowel involvement. He also didn't have any complaints of any fever, night sweats, cough, or significant weight loss. Patient also complained of headache, patient didn't also complain of headache, vomiting, any seizure or any loss of consciousness. He also didn't have any significant dermatological lesions like cutaneous stigmata. He also didn't complain of any muscle cramps, any involuntary movements, any improvement in stiffness with medication. There was no aggravating or relieving factors. There was no postural or diurnal variations. There was no loss of perianal sensations. And there was no aggravation of his complaint with neck movement. Coming to past medical history, he didn't have any such kind of similar complaints in past, and didn't have any trauma, hypertension, diabetes, any history of a stroke, surgery, or any post-COVID. Coming to family history, he didn't have any significant family history with such complaints. Personal history was normal, with no history of any drug allergy. To summarize my case, he was an 18-year-old male patient with no comorbidities. He had asymmetric spastic paraparesis with more on left side, which was insidious in onset, gradually ascending progression since last 5 months. He also had difficulty walking since last 15 days. His bilateral lower limb numbness till subcostal region, no bowel and bladder involvement, and no significant past history. So what are the possibilities you think can be happening to this patient? Any guesses? See, there was no complaint of headache, no history of any loss of consciousness, any seizures, or any unilateral involvement because it was bilateral. So we can rule out cranial causes. And secondly, in upper cervical or CV junction, we can rule out because there was no aggravation in complaints with his neck movements, and his upper limbs were also spared, so cervical can be ruled out. So it is subcostal or upper abdomen region, so it comes around the D8 and D9 level, so we can suspect any lesion above D7 level which is causing these problems. Now we have to rule out one by one that what can be. So coming to the possibilities, we can think of the following possibilities like trauma leading to prolapse intervertebral disc or listhesis or fracture. Next we can think of neoplastic etiologies like extradural or interdural extramedullary or intermedullary lesions, infective etiologies like bacterial, viral or parasitic, any vascular malformations like aneurysms, pseudoaneurysms or hematoma, inflammatory like transverse myelitis, autoimmune diseases like Guillain-Barré syndrome, multiple sclerosis or neuromyelitis optica, and congenital like diastematomyelia or Tether cord. So here on the basis of history you can rule out few things like there was no history of trauma, no history of any pain, no history of any aggravation to his symptoms to movements. So we can rule out PIVT, listhesis and spinal fractures. Next we can rule out intramedullary lesions because in intramedullary we can see there are symptoms which are like funicular type of pain, early bladder and bowel involvement. His symptoms are mostly symmetrical and descending sensory and motor loss is there. Lower motor neuron is widely spread and there is late upper motor neuron signs and dissociative sensory loss is there. So these things are not seen in our patients, so we can rule out intramedullary from here. Nextly we can rule out bacteria because there was no history of any fever, night sweats, cough or any significant weight loss in past history or any pain in the local region. And nextly, viral we can rule out because there was no history of any fever or myalgia or something like that. Next we can rule out inflammatory because it is a quite long history, chronic history of 5 months. Next in autoimmune diseases because upper limbs are spare, facial muscles are spare and it was asymmetrical, so we can rule out all these things. And in congenital there was no sensory motor and bladder involvement, no cutaneous stigmata. So we can rule out diastematomyelia and Tether cord. Sir, bacteria.
Prime Minister is a minister, but he has to be mentioned separately.
Physical examination, patient was conscious, cooperative, well oriented time, place and person. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. The vitals were within normal limits with the BMI around 24.6 kg per meter square. And on local examination, there was no visible spinal deformity or no spinal tenderness. In systemic examination, his respiratory, cardiovascular and para-abdomen were within normal limits. In CNS, it was within normal limits with no cerebral signs or no signs of a meningeal irritation. Coming to motor examination, his upper limb were within normal limits with normal bulk and tone. His power of shoulder, elbow and wrist were within 5/5 and grip was 100% in both hands. Coming to examination of lower limbs, his bulk was around 25 cm mid-thigh and 24 in left side mid-thigh, and there's a little less in compared to right side. His tone is increased in bilateral lower limbs with significant power loss in both the hip, in all the hips, knees and ankle. Here we can see the most significant thing is in ankle dorsiflexion. You can see 2/5, which denotes here there is foot drop in this patient. So coming to motor examination of deep tendon reflexes, here we can see the jerks of the upper limb are within normal limits with exaggeration in knee jerk and also exaggeration in ankle jerk. There was also ankle clonus present bilaterally, which was sustained in nature, and there was left-sided foot drop. Along with his pararectal examination was normal anatomy. Coming to abdominal reflexes, it was normal on right side but little diminished on the left side, and Babinski reflex was positive in both his lower limbs. Yes, sir. Babinski reflex is a dorsiflexion of the great toe and fanning of the other toes, along with dorsiflexion of the ankle, flexion of the knee and hip, and which happens when we stroke a blunt object from heel to the little finger and towards the great toe, and it signifies any corticospinal tract involvement or upper motor nerve involvement. Coming to sensory system, we can see there was a decreased sensation to pain, temperature and light touch below D8 and D9 level, but his crude touch, 2-point discrimination, sense of joints position and passive movement and vibration was normal. So these are the things to rule out the dorsal column involvement. Here is the patient which was we examined, and here is the gait of the patient. Here we can see patient is walking with support of the bystander, where we can see significant weakness in his motor. If you watch carefully, you can see patient is actually dragging his left foot. So it's a kind of steppage gait. Coming to examination, we can see a quick demonstration of motor tone and reflex. First of all, straight leg raising test is done to showing negative results bilaterally. Next, we observe motor power of bilateral lower limb showing significant weakness. Here we are checking the tone and the clonus of the patient. Here is the demonstration of positive Babinski reflex, and here is a demonstration of positive clonus, which is sustained in nature. When there is more than 10 flaps, we call it sustained clonus. To summarize my history, patient is an 18-year-old male patient with spastic paralysis, more on left side, insidious in onset, gradually progressive over last 5 months. He had difficulty in walking in last 15 days. He had numbness till subcostal region, no cerebral cranial nerve involvement, no bladder and bowel involvement. To summarize my examination, he had prominent motor weakness more on the left side compared to right side. He had significant left-sided foot drop. His trunk muscles were weak. His deep tendon reflexes were increased in bilateral lower limbs, and bilateral ankle had clonus present. And to sensory, he has decreased sensation below D8 and D9 level along with steppage gate. So we can suspect any lesion above this subcostal region with D8 or D9 level, any lesion on D7 or above that. After the examination, so my neurological diagnosis can be is an mostly extradural involvement.
Upper motor neuron or lower motor neuron?
Lower motor neuron palsy.
Gradual onset, acute onset.
Gradual progressive onset.
So पूरा बात बोलो ना.
बताया
Full neurological diagnosis. UMN or LMN?
UMN, upper motor neuron.
So how do you explain the foot drop?
Because there is motor weakness in his left ankle, which was 2 by 5. 2 by 5 means he cannot lift anything against the gravity, so we can call that foot drop.
So now what are the structures involved? What are the tracts and structures involved? अब neurological diagnosis जैसे बोलते हैं पूरा बोलो ना यार एक sentence में.
So there must be corticospinal tract involvement. Because of that, there is motor weakness.
What else? What other tracts?
And along with that, spinothalamic tract involvement is also seen, because that's why the sensations are less in.
Okay, and what is the site of lesion?
Site of lesion, because we are seeing that there is a band-like sensation in upper abdomen and subcostal region. It comes under D8 and D9 levels, so we can suspect any lesion above that level.
What is the vertebral level and what is the spinal level?
So vertebral level is +2, so this will be D10 or D11 level.
What are the possible etiologies? ये सारा कुछ बोलते हैं ना neurological diagnosis में. This all these things you speak in the neurological diagnosis, no? Gradual onset, slowly progressive, upper motor neuron. Just say that whole sentence.
Patient is having a bilateral paraparesis more on left side, which was gradually onset, asymmetric, which was insidious in onset, gradually progressive. It had upper motor nerve involvement, which signifies corticospinal tract. Also had corticospinal tract and spinothalamic tract, both involvement is there. His site of lesion is suspected above D7 level and vertebral level around D5, D6 level.
Any radicular involvement, radiculopathy?
There was no radicular or funicular cancer. Now I would like to invite Dr. Pragya Soni from radiology to further discuss the case, and after blood investigation we have done the radiological investigation. Thank you.
Good morning, respected teachers and my dear colleagues. I'll be discussing the radiological findings in this case. To start with, we'll discuss the normal MRI dorsal spine. These are T2 axial and sagittal T2 weighted axial and sagittal images. In these, we can see that this is the vertebral body. These are pedicles. These are transverse processes. These are the laminae, and this is the spinal process. This is the spinal cord, and this is the thecal sac which is containing the CSF, which appears right on T2. In the sagittal sequence, we can see that these are the vertebral bodies, these are the intervertebral disc, the spinal cord, the posterior elements, and the spinal cord is surrounded by the CSF. These are the images of our patient. The MRI was done elsewhere. In the T2 and stir images, there is evidence of altered marrow signals involving the posterior aspect of the vertebral body as well as the posterior elements. Associated posterior epidural soft tissue component is also seen at D5, D6 and D6, D7 vertebral levels, causing central canal narrowing and severe cord compression with few hypointense areas within the lesion, which can be likely due to calcifications. There is also hyperintensity seen in the cord, which is suggestive of cord edema. In the axial T1 and T2 images, on T1 images we can see that the boundaries of the lesion in the vertebral body as well as the posterior elements are not well delineated because the lesion is iso to the surrounding muscles. Then there are few fat intensity bright areas and discrete small rounded hypointensities which are likely due to the calcifications which are giving the characteristic polka dot appearance. The lesion appears hyperintense on T2 weighted images with soft tissue component of the lesion in the epidural space which is extending up to the left neural foramen. We can also see that the soft tissue component is severely compressing the spinal cord. These are the post-contrast sequences. As compared to the non-contrast sequence, we can see that the vertebral body component is mildly enhancing. However, the soft tissue component is intensely enhancing in this region. These are the similar post-contrast sagittal and coronal images where we can see that the soft tissue component is intensely enhancing in post-contrast sequences. So here, I would like to ask the audience, what could be the provisional diagnosis based on these MRI findings? This is a characteristic appearance of the disease. Alright. So, on the basis of features like T1 hypo and T2 hyperintense lesion with intense enhancement and giving the characteristic polka dot appearance, our provisional diagnosis is aggressive hemangioma. To further characterize the lesion and look for feeding vessels, CT angiography was advised. In non-contrast CT bone window images, this is at the level of D6. Mild bony expansion is seen involving left posterior aspect of D6 vertebral body with involvement of bilateral pedicles, lamina, transverse processes. On axial non-contrast sequence, we can also see prominent trabeculae and striations giving the polka dot appearance. In the sagittal sequence also, we can see that the trabeculae are prominent. The associated posterior extraosseous epidural partially calcified soft tissue component is seen at D5, D6 level. In the soft tissue window, in the non-contrast axial sequence, we can see that the soft tissue component has calcific components within it, and on post-contrast sequences, it is intensely enhancing. Here's a video of the CT angiography where we can see that this is the arch of aorta, the descending aorta, the vertebral body. This is the spinal cord, and here behind the spinal cord we have the epidural soft tissue intensely enhancing component. We can also see that a branch is coming from posterior aorta which is supplying the soft tissue component. These are the posterior intercostal arteries. In the volume rendered image, we can see that this is the descending aorta through which these are the posterior right intercostal vessels or arteries, and here these are the left intercostal arteries. We can clearly see that the soft tissue component of the lesion is far away from the right intercostal arteries, and no branch is supplying this soft tissue component from the right side. However, on the left side, these are two feeder vessels from D5 and D6 which are supplying this soft tissue component. Here also we can see that this is the descending aorta, the posterior intercostal vessel supplying this soft tissue component. In this video also, we can see that this is the ascending aorta, the arch of aorta, the major vessels coming out of the arch of aorta, the descending aorta, and posterior to the descending aorta, we have the intercostal vessels. So, at this point, the CT angiography has enhanced the diagnosis that we have already made, which is the aggressive vertebral hemangioma. According to ISSVA classification, the vascular anomalies are divided into two categories, which are the vascular tumors and vascular malformations. The vascular tumors consist of tumors which are due to endothelial proliferation, and in hemangioma is a benign vascular tumor which is under this category. In vascular malformations, other AV malformations are included. The other close differentials could have been solitary plasmacytoma of vertebral body. However, the age of presentation of plasmacytoma is 40 to 50 years. Secondly, the absence of characteristic mini brain appearance rules out this diagnosis. Basically, in mini brain appearance, there are curvilinear low signal intensity areas within the lesion, giving the appearance of sulci and gyra in the brain. The other diagnosis could have been osteoblastoma, which presents in 20 to 40 years of age. However, the characteristic bubbly appearance is not seen in our case. And also, the lesions of osteoblastoma are predominantly lytic, which was also not our case. Thank you. I would like to call Dr. Shub to carry forward the case.
So, taking the case forward, our final diagnosis was on the basis of history and clinical examination and radiological findings that there is a extradural vascular lesion at D5, D6 level causing severe cord compression. So, what are our treatment options? For this lesion, there is no medical treatment as there is significant compression on the spinal cord. Our first option was direct surgical intervention with resection of the hemangioma and decompression of the cord. Another option was to do endovascular embolization first, but after discussing the case with our intervention radiology team, we came to conclusion that the hemangioma is high flow with non-feasible anatomy, where alcohol is a fast flowing material causing high risk of misembolization. Sometimes reactionary edema can also be caused by embolization, further worsening the cord compression. Hence, we opted for surgical resection and decompression of the cord, as it is also the gold standard option. Other options are like ethanol injection applying to the epithelial layer and radiotherapy, which also can be an option. Especially these are for old patients where surgical intervention are not possible or where there is more comorbidities. Next, we planned our surgery to be D5, D6, D7 laminectomy and resection of the extradural hemangioma with adequate spinal cord decompression along with cord and root preservation. So how we did it? After patient being induced by our neuroanesthesia team, patient was position prone, specially equipped OT table. Here patient lies on their stomach with their spines flexed, facilities access to the dorsal spine. Under CM guidance, position of spinal level is being done. With midline incision along the dorsal spine was taken, which allows the precise direct access to the tumor. Next, careful dissection of the soft tissue. Here overlying the spinal process and lamina is done. Here exposing the spinal process, followed by removal of the D5, D6 and D7 spinal process and a portion of the lamina to expose the underlying spinal cord and the hemangioma. Here is the video of a laminectomy process after removal of D5, D6, D7 spinal process. Here we are removing the lamina part of the spine with Garrison punch in piecemeal manner, ensuring careful dissection, ensuring minimal damage to the underlying dura and hemangioma. We are carefully exposing the extradural tumor to ensure minimal blood loss and exposing all the feeding arteries. Here we can notice more than normal blood loss during laminectomy process due to increased vascularity of the peritumoral region. And after laminectomy is complete with adequate hemostasis, dura and hemangioma is being exposed. So the next step was branches of the feeder arteries supplying the tumor are carefully identified, cauterized and cut to reduce blood flow to the tumor. This step helps control bleeding and facilitates the safe and efficient removal of the tumor. Tumor boundaries are carefully identified using visual inspection and surgical instruments. Dura mater, the protective covering of the spinal cord, is carefully preserved during the resection process, and specialist instruments are used to carefully remove the tumor in piecemeal manner, avoiding damage to the surrounding tissues. Here we can see after laminectomy, here we are doing the resection of the hemangioma. We can see the significant cord compression is there caused by the hemangioma. Here we are identifying and separating the feeder arteries, cauterizing and then cutting them. By doing this, we are devascularizing the tumor. This white cord-like structure is the spinal cord. While doing resection, care must be taken and not to damage this dura. With continuous saline irrigation and bipolar cautery, tumor is resected in a piecemeal manner. All the feeder arteries are identified carefully and cauterized. Care must be taken as it's a highly vascular tumor. Our highly efficient neuroanesthesia team and blood bank was pre-equipped and prepared for any kind of emergencies. Gently, all the extradural tumor was taken out with adequate decompression of the spinal cord. Here we are taking the tumors in piecemeal manner. And finally, after doing this, we can see there is the decompression of the spinal cord. And after total resection of the extradural hemangioma, if you watch carefully, you can also observe the cord pulsation is present. Here we can see an increased vascularity over the spinal cord because of the hemangioma. This is not normal. This much vascularity is not seen in normal spinal cord. This is a small part of the tumor sent for the biopsy specimen. The surgery went uneventful, which lasted around 3 hours, and we are thankful to our neuroanesthesia team for their constant support. Around 350 ml blood loss was there, which can be considered quite decent in this type of surgeries. Patient was shifted to ICU. Postoperative recovery went uneventful. On day 2, patient was shifted to ward and Foley's and drain was removed. Patient was mobilized on day 3 and followed by physiotherapy. On day 5, patient was discharged. Neurological assessments were performed routinely to monitor patient's recovery and ensure that there were no significant neurological damages. An immediate improvement in motor power was observed in our patient. Here we can see the pre-op video where he was walking with support and dragging his foot. The next video is a post-op day 4 of the patient. Here we can see patient was able to walk without any help with telebrace support with significant improvement in his steppage gait. In 1 month follow-up in our OPD, we can see there is significant motor power increased, which is very promising, and there is much improvement in his gait and motor powers. And there is also patient can walk now with slippers, which he was not able to do previously. And here is a recent 6 months follow-up in our neurosurgery department. The patient is asymptomatic with complete resolution of bilateral lower limb power and having a totally normal gait.
Can you go back? This for the residents, not just for steppage. You get pre-op first.
All the respected teachers and my fellow colleagues. So histopathologically we received formalin fixed specimen in 2 different containers. One was having bony tissue pieces and another one was having soft tissue pieces of varying measurements. So on microscopic examination, section studied on various magnifications which show predominantly thin wall dilated vessel wall, some large blood field spaces which are lined by the endothelial cells, and some thin walled capillaries and blood vessels of intermediate diameter which show transitioning between the capillary and cavernous hemangioma. Some bony fragments are also seen here. So on the basis of these microscopic features, a final diagnosis is cavernous hemangioma. Thank you.
I would like to now invite Dr. Manoj Agarwal sir from our neurosurgery department to further discuss of the review of literature.
Once again, here we are. So far till date, only 90 cases of cavernous hemangioma have been reported. During the longest series of 9 cases, the hemangiomas consist of 4% of all epidural tumors. These are purely epidural lesion and 12% of all interspinal hemangiomas. we classify them as a capillary telangiectasis, cavernous hemangiomas, capillary hemangiomas, arteriovenous and venous malformations. This is one of the study between the January 2005 and December 2019. Only this is the largest case series in which only 9 cases have been reported, which is done in China, and it's published in original research paper in 2022. One is again a study in this interdisciplinary neurosurgery. They said that surgical excision with a gross total dissection is the treatment of choice for cavernous malformation of the spine, and there is no role for endovascular embolization. And in Curious Journal in 2023, they said that cavernoma is embryologically supposed to be endothelial cell origin. Extension of the epidermal mass into the neuroforamen is possible. Originate from the dysplastic blood vessel. Progenitor might develop from the gradual increasing telangiectasis. Basic fibrous growth factor, vascular endothelial growth factor are the pro-angiogenic molecules and are often produced by the tumor cells. So our take-home message is epidural hemangiomas are rare entity. Hemangiomas should be considered in the differential diagnosis of the epidural lesions. Meticulous planning with a multidisciplinary team approach. Surgery remains the gold standard treatment. Early and timely diagnosis of utmost importance. We operated this hemangioma with progressive lower limb weakness in our center with tremendous result and full functional recovery. Our last CCR on the extradural arachnoid cyst was also published in PubMed Index in IJMACR in April 2024. And I would like to special thanks to the MGUMST management to providing the world-class facilities and giving all the instruments and the equipments that we needed. Our radiology and intervention radiology department, our neuroanesthesia team that keep the patient stable throughout the surgery, pathology team for the making the diagnosis of the cavernous hemangioma, blood bank, and the PMR physiotherapy rehabilitation process, and the CCR reviewing committee. And last but not the least, patient and family members who trusted on us. Thank you so much for this.